Welcome to the Deep Dive. We're here to cut through the noise and get you the vital information you need. Today we're jumping into a really essential system, the vascular network. It's dynamic, complex.
Absolutely vital. And when things go wrong here, the impact on a patient's life, it's huge.
Exactly. So mastering this area isn't just academic for you nursing students, it's critical for your practice. We're doing a special deep dive into vascular disorders, and we're pulling key insights from Lewis's medical surgical nursing.
Right. Our goal is a comprehensive overview, but, clear and focused.
So what's the mission today?
Okay, our mission is really to unpack the complexities. We're talking arterial, venous, lymphatic problems. We'll walk you through it all step by step. Pathophysiology, those crucial risk factors, what the patient actually looks like, the clinical manifestations.
The tests you'll see ordered.
Essential diagnostic tests,
Yeah.
And most importantly, what you do about it, the nursing management. Think of this as like your shortcut to understanding not just what these are, but why they matter so much in patient care.
Perfect. And this is tailored for you, college nursing students. We want to make those dense medical terms clear. We'll really spotlight the nursing process, assessment, education, the whole thing.
And help build that critical thinking, right? Like you need for the NCLEX.
Definitely. We'll even describe important charts and tables verbally so you can follow along without the book right in front of you.
Grounding it all in real-world scenarios.
Okay, let's start foundational. Vascular system problems. Arteries, veins, lymphatics. When something goes wrong, what's the immediate kind of overarching impact?
Well, what's really interesting is that the common thread, across most of these disorders, it often boils down to decreased perfusion, ischemia, not enough blood flow getting to those peripheral tissues.
And for the patient, that means
challenges, big ones, pain, problems moving, just doing basic daily activities, ADLs. So if you connect that to the bigger picture, prevention becomes massive for nursing. We're talking health promotion, good nutrition, definitely smoking cessation, exercise, plus safety, especially if they're on anticoagulants, huge fall risk implications there.
So it really hits their whole functional life. Now, Lewis's classifies arterial disorders, atherosclerotic, aneurysmal, non-atherosclerotic, quite a few categories.
Yeah, it does.
For today's deep dive, we're going to focus mainly on peripheral artery disease, PAD, then aortic aneurysm and dissection, and after that, we'll tackle venous diseases. Sound good?
Sounds like a plan. Let's start with PA.
Okay, PAD. Let's picture a patient. Maybe Mr. Davies, 68, used to smoke. He tells you his calves cramp up whenever he walks his dog, like clockwork. But it stops when he rests.
Ah, the classic story. That points right to PA.
It involves that thickening of the artery walls, right? Leading to progressive narrowing, usually lower extremities.
Yep. And it really ramps up with age. Typically hits between 50 and 70.
And even earlier if the patient has diabetes.
Right. The source also highlights something important. Prevalence is highest in the Black population in the U.S.
That really stood out. It suggests potential underdiagnosis, undertreatment. Yeah. Something we as nurses really need to keep in mind with our patients.
Definitely. Awareness is key.
So, the main cause behind PAD.
It's mostly atherosclerosis, that gradual thickening, the intima and media layers of the artery from cholesterol and lipid deposits. And here's the tricky part for nurses. These blockages, they often get pretty bad before any symptoms even show up.
How bad?
Usually symptoms only kick in when the vessel's blocked, like 60% to 75%, which is significant.
Wow. So screening for risk factors early is crucial.
Exactly. You're looking for clues before it gets that severe. Inflammation, endothelial injury, they play a big role too. It signals a more systemic issue.
Okay. Thinking back to Mr. Davies, with his smoking history, maybe diabetes.
Yeah.
What are the absolute must-know risk factors, especially the ones we can actually do something about?
Great question. Because while you can't change age or genetics, tobacco use, that's the #1 modifiable risk factor, hands down.
So helping patients quit.
It's huge. Complete cessation of all tobacco, even marijuana, according to the text, that can have more impact than medication alone sometimes.
What else?
Diabetes, hypertension, high cholesterol, all major players. And the thing is, having multiple risk factors, it doesn't just add up, it multiplies the risk dramatically.
Like that compounding effect. Okay, back to Mr. Davies' symptoms. That cramping pain with exercise.
Intermittent claudication, that's the classic one for you to remember. It's ischemic muscle pain.
Caused by exercise, resolved with rest. Consistently.
Exactly. Think lactic acid buildup, because those muscles just aren't getting enough oxygen when they're working hard.
And where the pain is can give clues, right?
Precisely. But thigh pain might mean iliac artery issues, calf pain, more likely femoral or popliteal arteries. And as PAD gets worse, patients can develop rest pain.
That sounds worse.
It is often happens in the feet or toes, especially at night when cardiac output naturally dips a bit.
And they find relief how?
Typically by dangling the leg over the side of the bed. Gravity helps pull some blood down.
You might also see paresthesia.
Yeah.
That numbness and tingling.
Yep. In the toes or feet. And eventually, if it progresses really far, critical limb ischemia, or CLI. CLI means chronic rest pain for more than 2 weeks, or ulcers that won't heal, or even gangrene. It's serious.
And the leg itself looks different.
Definitely. Key assessment findings. The skin gets thin, shiny, kind of taut. Hair loss on the lower legs. Pulses are decreased or totally absent. You'll see elevation pallor, foot goes pale when you lift it up, and dependent rubor turns reddish when it's down. These signs scream poor blood flow, urgent.
And complications. Prolonged ischemia means healing slows way down.
Leads to infection, tissue death, necrosis, those non-healing arterial ulcers, especially over bony spots like heels or ankles, and gangrene. They're severe. Sometimes amputation is the only option.
So how do we diagnose PAD officially?
We've got tools. Doppler ultrasound with duplex imaging is great for mapping blood flow, especially if you can't feel pulse as well. Segmental BPs are also key. You take DPs at different levels of the leg. A drop of more than 30 millimeter Hg between segments suggests PAD.
But the main screening tool?
Probably the ankle brachial index, ABI. Super important for you to understand.
How's that calculated?
You divide the ankle systolic blood pressure by the higher of the two brachial systolic pressures. Simple ratio.
And what number are we looking for?
An ABI of 0.90 or less, that indicates PA. And the lower the number, the more severe it is. Like 0.40 or less is severe PAD. That ABI value is your red flag.
Good to know. Is it always accurate?
Well, there's a catch. In older patients or those with long-standing diabetes, the arteries can get calcified and hard. That can give a falsely high ABI reading. So you always have to look at the whole clinical picture, the patient's symptoms.
Right. Context is everything. So managing PA, thinking about Mr. Davies. What are nursing priorities? Where do we even start?
First things first. Aggressively tackle those cardiovascular risk factors.
Smoking cessation again?
Non-negotiable. Plus, dietary changes, DSH diet, Mediterranean diet are good options. Tight glucose control for diabetics, aiming for an HbA1c below 7.0%. And lipid management, usually with statins.
And for the claudication itself, like Mr. Davies' calf pain.
Structured exercise programs are actually highly recommended. Walking programs. And meds like silostazol can help improve walking distance.
Ah, silostazol. Quick drug alert. I remember something important about that one.
Yes, good catch. It's contraindicated in patients with heart failure. Always check that cardiac history before it's prescribed or administered.
Crucial check. What about patients with CLI, that critical limb ischemia?
For them, revascularization is often the goal, getting blood flow back. That might mean bypass surgery using one of the patient's own veins, ideally, or maybe PTA percutaneous transluminal angioplasty, often with a stent. If surgery isn't an option or while waiting, conservative management is key. Protect the limb from any injury, manage pain, control infection risk, and meticulous foot care.
What does meticulous foot care involve here?
Things like inspecting feet daily, keeping them clean and dry, wearing well-fitting shoes, avoiding temperature extremes, and definitely not soaking feet, which can cause skin breakdown, or using harsh chemicals. Nurses also care for patients after those procedures, PTA, atherectomy, bypass surgery. Post-op care is intense.
How intense?
You're doing checks every 15 minutes initially. Color, temp, cap refill, pulses comparing to the other leg sensation, movement, any change, even subtle, reported immediately.
Looking for complications like
Bleeding, hematoma, but also graft thrombosis, the bypass clotting off, that's an emergency.
and long-term for discharge.
Patient education is huge. Lifelong antiplatelet therapy, usually aspirin or clopidogrel. Proper foot care, daily self-checks, avoiding sitting with legs crossed or for too long.
Yeah.
Basically empowering them to manage it.
Okay, let's shift gears from that chronic narrowing of PAD to something sudden.
Yeah.
Acute arterial ischemic disorders.
Right, this is when blood supply gets cut off abruptly. A critical interruption.
Can lead to tissue death really fast.
Extremely fast. Often caused by an embolus, a traveling clot, maybe from the heart, especially with conditions like atrial fibrillation. That's the most common cause.
Or a thrombus forming right there in a diseased artery or trauma.
Exactly. And this is a true emergency. Nurses have to recognize the signs.
The famous 6 Ps.
You got it. The 6 Ps. Pain severe, sudden onset. Pallor of the limb looks white, waxy. Pulselessness, no pulse distal to the blockage. paresthesia, numbness, tingling. Paralysis, inability to move the limb, that's a very late, very bad sign. And poikilothermia, the limb feels cool to the touch, takes on the room temperature.
See those signs, what do you do?
Immediately notify the healthcare provider. Time is tissue, literally. Waiting can mean losing the limb. Ischemia progresses to necrosis and gangrene in just hours sometimes.
Recognizing those 6 Ps is the urgent call to action. So treatment.
Early diagnosis, immediate treatment. Anticoagulation right away, usually IV unfractionated heparin to stop the clot from getting bigger or more clots forming. Then, get the clot out, surgical thrombectomy, maybe catheter-directed thrombolysis to dissolve it, or surgical bypass if needed.
Okay. Beyond atherosclerosis, Lewis's mentions a couple of other specific arterial disorders. Berger disease.
Thromboangiitis obliterans, yeah. Berger disease. It's different because it's not atherosclerotic, it's an inflammatory disorder. Affects small and medium arteries and veins, mostly arms and legs.
And the typical patient profile.
Predominantly men, usually under 45, with a significant history of tobacco or marijuana use. Often they don't have the other typical cardiovascular risk factors like high cholesterol.
What's happening in the vessels?
There's inflammation and thrombus clots form, blocking the vessels. Leads to ischemia.
So symptoms might look like PAD initially?
Sort of intermittent claudication, but it can be in the feet, hands, or arms. Then it progresses to rest pain, ischemic ulcers. They often have cold sensitivity too, like Raynaud's.
And the number one nursing intervention.
Emphasize and support complete cessation of all tobacco and marijuana use. It is the only way to stop the disease from progressing. Nothing else works nearly as well.
That's a powerful message. Okay, and the other one was Raynaud's phenomenon.
Right. Raynaud's is different again. It's episodic. Vasospastic. Affects the small cutaneous arteries, mostly fingers and toes.
More common in women, right? Younger women, 15 to 40.
Correct. And it's characterized by those really dramatic color changes triggered by cold or stress.
White, then blue, then red.
Exactly. White or pallor from the vasospasm cutting off blood flow. Then bluish-purple, cyanosis, as the trapped blood loses oxygen. And finally red, rubor, as blood flow rushes back in during the hyperemic phase.
That feels strange.
Patients report coldness and numbness during the white-blue phases, then throbbing pain, tingling, swelling when it turns red.
So nursing care is mostly about prevention.
Primarily teaching. Avoid cold exposure, wear gloves. Manage emotional stress. Avoid tobacco, caffeine, and any drugs that cause vasoconstriction, like some cold meds.
Any medications for Raynaud's itself?
Yeah, sustained-release calcium channel blockers are often first line. They help relax the smooth muscles in those small arteries, reducing the vasospasm.
All right, let's move to the big one, literally. The aorta. Aortic aneurysms?
Yeah, these are weak spots in the body's largest artery. An aneurysm is a permanent, localized outpouching or dilation of the vessel wall.
And most happen where?
About 3/4 are in the abdominal aorta AAAs. Thoracic aortic aneurysms, TAAs, are less common but also serious.
Causes.
Risk factors.
Main cause is degenerative changes in the vessel wall, but risk factors look familiar. Age, male gender, hypertension, coronary artery disease, family history, and guess what's the most important modifiable risk factor again? Let me guess. Tobacco use.
Bingo. Smoking is strongly linked.
Lewis's classifies them as true or false aneurysms.
Right. A true aneurysm involves the arterial wall layers, at least one layer is intact. Can be fusiform, kind of spindle-shaped all around, or saccular, like a little pouch on one side. A false aneurysm, or pseudoaneurysm, isn't really an aneurysm in the same way. It's a disruption of all the layers, and the bleeding is just contained by the surrounding tissues. Often happens after trauma or a procedure, like cardiac cath.
Important distinction for treatment, I imagine. What about symptoms?
Thoracic ones, TAAs, can cause deep chest pain, sometimes mimicking angina. If they press on structures, maybe coughing, shortness of breath, difficulty swallowing. AAAs, though, often totally asymptomatic. The silent killer moniker fits. Might be found incidentally on an X-ray or CT for something else.
But if they do cause symptoms?
Could be a pulsatile mass you can feel in the abdomen, around the belly button, or you might hear a bruit with your stethoscope over the area. Back pain is also possible if it presses on vertebrae.
And the biggest fear with any aneurysm is?
Rupture. Absolutely terrifying complication.
What happens then?
If it ruptures into the chest or abdominal cavity, massive hemorrhage. Patient goes into hypovolemic shock fast. Tachycardia, hypotension, pale clammy skin, decreased urine output, altered consciousness, abdominal tenderness. If it ruptures into the retroperitoneal space, the area behind the abdominal lining, they might have severe back pain and maybe flank bruising. That's called Gray-Turner sign.
See those signs? It's code blue time.
Pretty much. Immediate surgical intervention is the only chance, and even then, mortality is incredibly high.
How are they diagnosed before rupture?
Chest X-ray might show a widened aorta for TAAs. Abdominal X-ray might show calcification. Echocardiography can visualize the aortic root, but ultrasound is really useful for screening for AAAs and monitoring their size over time. CT scans and MRI give the most detailed images of the location and size.
Okay, management. If it's small and not causing symptoms.
For small AAAs, say less than 5.4 centimeters, the approach is usually conservative. Aggressive risk factor modifications stop smoking, control blood pressure and lipids, and regular surveillance imaging like ultrasounds every 6-12 months to watch its size.
But if it gets bigger?
Yeah, threshold for repair is generally 5.5 centimeters or larger. Or if it's growing rapidly or if the patient is symptomatic, then surgery is recommended.
What are the surgical options?
Two main ways. The traditional open aneurysm repair, or OA. Big surgery. Open the abdomen, clamp the aorta, cut out the aneurysm, sew in a synthetic graft. Then there's the less invasive option, endovascular aneurysm repair, or EVA.
How does EVAR work?
They go in through the femoral arteries in the groin, thread up a collapsed stent graft, and deploy it inside the aneurysm, essentially relining it and excluding the weak spot from blood flow.
Sounds much easier on the patient.
Recovery is definitely faster, fewer complications right after surgery. And this is a big, but EVAR requires lifelong follow-up imaging.
Why?
To check for endoleak. That's where blood manages to seep back into the aneurysm sac around the graft. If that happens, the TAC can still expand and potentially rupture. So you need those regular CTs or ultrasounds forever.
Got it. Nursing care after either type of aortic surgery must be intense.
Incredibly intensive, especially after OAR, but EVR too. Your immediate focus is graft patency, checking pulses, color, temp in the legs constantly. Blood pressure management is critical. Too low, the graft might clot off. Too high, you risk bleeding at the suture lines or graft connections. Fine line to walk.
What else are you monitoring?
Cardiovascular status, heart rhythm, signs of MI, infection risk. GI status, postoperative ileus, where the bowel shuts down, is really common after OAR. Neurological checks. And renal perfusion, watching urine output like a hawk, hourly. Kidneys can take a hit if blood flow was clamped off for too long during surgery.
And for discharge, after they get through that acute phase?
Gradual increase in activity, no heavy lifting for quite a while, usually 6 weeks or more. Lots of patient and caregiver education.
On what specifically?
How to monitor their extremities for changes. Wound care, the absolute need for lifelong blood pressure medication. And something often overlooked, sexual dysfunction in male patients is common after aortic surgery. So they need education and possibly referral for that.
Okay, we've covered the high-pressure arterial system. Let's switch to the veins. Lower pressure, but its own set of problems.
Right.
Often related to stasis, clots.
Exactly, a different dynamic. Let's touch quickly on phlebitis first. You'll see this a lot.
Inflammation of a vein, usually from an IV.
Yep, small, superficial veins, often where an IV catheter was, causes pain, warmth, redness, maybe a palpable cord along the vein, usually resolves quickly once you take the IV out. Warm compresses, maybe NSAIDs can help. Pretty straightforward.
Okay, now the bigger issue. Venous thrombosis includes SVT and DVT.
Right. Superficial vein thrombosis and deep vein thrombosis. The umbrella term we often use now is venous thromboembolism, or VTE, because that covers both DVT and its most dangerous complication, pulmonary embolism, or PE.
And the key concept for understanding VTE risk.
Virchow's triad. You absolutely need to know this. 3 factors that contribute to clot formation.
What are they?
1, venous stasis, blood pooling, not moving well. Think obesity, pregnancy, heart failure, atrial fibrillation, long trips, prolonged immobility after surgery. Endothelial damage, injury to the inner lining of the vein. Can happen from surgery, trauma, IV catheters, certain medications, anything that irritates that vein wall.
And 3.
Hypercoagulability, blood that's just more prone to clotting. Seen in cancer, sepsis, dehydration, high altitudes, and with medications like estrogen therapy or oral contraceptives, especially in women over 35 who smoke. Smoking itself increases fibrinogen.
So understanding the triad helps you assess risk in pretty much any patient.
Any patient, it's fundamental.
Okay, what do these clots look like clinically? SVT first.
SVT, that superficial one, often looks like phlebitis, but maybe a bit more expensive. Palpable, firm, cord-like vein, itchy, tender, painful, warm, red, often happens in varicose veins.
And VTE, the deeper ones?
Maybe asymptomatic, but classic signs are unilateral leg edema, just one leg, swelling pain, tenderness when you palpate, warmth, redness, sometimes a sense of fullness in the thigh or calf.
Complications are the big worry here.
Huge. PE is the most serious. A chunk of that DVT breaks off, travels through the heart, lodges in the pulmonary artery. Life-threatening. Another complication is post-thrombotic syndrome, or PTS. Happens in maybe 20–50% of patients after a DVT.
What does PTS involve?
Chronic leg issues. Pain, aching, heaviness, swelling, cramps. And skin changes, persistent edema can lead to fibrosis, and that classic lipid or atherosclerosis.
That leathery, brownish skin.
Exactly, from hemosiderin staining. The skin gets thick, hard, contracted, makes it prone to break down and ulcers later, and rarely, very rarely, you can see phlegmasia cerulea dolens.
Sounds dramatic.
It is. Near total occlusion of venous outflow. The leg becomes massively swollen, deep blue or purple, intensely painful, can cut off arterial supply too, leading to gangrene. Very bad.
How do we diagnose VTE?
Starts with assessment, looking for those signs and risk factors.
D-dimer blood test is often used.
What does D-dimer tell us? It measures fibrin degradation products, fragments left over when a clot breaks down. If it's negative, VTE is unlikely. If it's high, it suggests VTE might be present, but it's not specific. Other things can raise it too, like infection or recent surgery. So a positive D-dimer needs follow-up.
And the follow-up test is usually?
Duplex ultrasound. It's the most common and reliable test. Uses ultrasound to visualize the veins, check if they compress normally, a clot stops compression, and look for clot filling the vein lumen. Table 41.9 in Lewis's lists other tests, but D-dimer and duplex are your mainstays.
Okay, VTE management. Prevention is key, right? Especially in hospitalized patients.
Absolutely critical. It's a core quality measure. Early and aggressive mobilization get patients walking, graduated compression stockings, and intermittent pneumatic compression devices, IPCs, those sleeves that inflate and deflate around the legs.
But there's a caution with IPCs.
Yes, important point. You do not use IPCs on a leg where there's an active known DVT. The worry is dislodging the clot.
Makes sense. What about medications?
Anticoagulant therapy is the cornerstone for both prevention in high-risk patients and treatment of existing VTE. Lots of options here.
Like warfarin.
Yep, vitamin K antagonist, warfarin. Requires regular INR monitoring, usually aiming for a target range of 2.0 to 3.0. Takes a few days to become therapeutic.
Heparin.
Unfractionated heparin, often given IV for acute VTE, requires monitoring with OPTT. And you have to watch out for heparin-induced thrombocytopenia, HIT. That's a serious allergic reaction where platelets drop, paradoxically causing more clotting.
There are also low molecular weight heparins, LMWHs.
Right, like an oxypirin, given subcutaneously. More predictable response, usually don't need routine monitoring like heparin, easier for outpatient use.
And newer ones.
The direct thrombin inhibitors and factor Zase inhibitors. Oral meds often don't require routine monitoring, fewer interactions than warfarin, becoming more common but can be expensive, and reversal agents aren't always readily available for all of them.
So lots of drug options. What's the nurse's role with anticoagulant?
Huge role. Meticulous administration, monitoring those coagulation tests, INR, APTT, when needed. And the absolute crucial part, monitoring for and managing bleeding risk. Lewis's has great tables on this table. 41.14 covers key nursing actions for bleeding risk, and 41.15 outlines essential patient teaching points for anyone going home on anticoagulants. Definitely review those.
So beyond the drugs, nursing focuses on assessing risk, putting prevention in place, checking the meds are working, watching for bleeding or PE.
Exactly. And comprehensive discharge teaching, medication safety dose, timing, monitoring what to do if they miss a dose, avoiding other meds like NSAIDs that increase bleeding risk, lifestyle changes, and crucially, recognizing signs of PE, shortness of breath, chest pain, cough, and seeking immediate help.
Let's do a quick NCLAX style check. You have a patient on an IV heparin drip for a big DVT. Their latest APTT comes back sky high, say 122 seconds. What's your first move?
Okay, critically high APT. Bleeding risk is extreme. First action, stop the heparin infusion immediately. Then notify the healthcare provider right away. And anticipate an order for the reversal agent, protamine sulfate. That immediate recognition and action stop, notify, anticipate, that's what saves lives.
Perfect. Okay, briefly, varicose veins. We see these a lot.
Yeah, those dilated, tortuous, ropey-looking superficial veins, often in the legs.
Risk factors.
Family history plays a big role. Also, female gender, maybe hormone-related. Obesity, jobs involving prolonged standing or sitting, pregnancy, anything that increases venous pressure.
Mostly cosmetic, or can they cause problems?
Often cosmetic, but they can cause symptoms. Aching, heavy feeling in the legs, swelling, leg fatigue, itchy skin over the veins, and they can be sites for superficial vein thrombosis.
How are they managed?
Conservative stuff first. Rest with legs elevated, graduated compression stockings, regular exercise like walking, weight loss if needed. If those don't help, or for cosmetic reasons, interventions range from sclerotherapy injecting a solution to scar and close the vein to endovenous ablation using heat, laser, or radiofrequency to collapse it. Sometimes surgical removal.
Nursing focus.
Prevention is big. Teach patients to avoid long periods of standing or sitting still. Encourage walking. Maintain ideal body weight. And emphasize correct use of those compression stockings. Proper fit is key.
All right, last major topic in this area. Chronic venous insufficiency, CVI, and venous leg ulcers.
Right. CVI is basically the advanced stage of venous disease. The valves in the veins are incompetent, may be damaged from previous DVTs, leading to chronic pooling of blood in the legs.
What does that look like?
Persistent edema, especially at the end of the day. That characteristic skin discoloration, brownish, brawny appearance from hemosiderin getting deposited in the tissues from broken down red blood cells leaking out. The skin can become thick, leathery, itchy. Eczema is common.
And this often leads to ulcers.
Yeah, venous leg ulcers or stasis ulcers. They typically occur around the medial malleolus, the inner ankle bone. They're often shallow, irregular borders with drainage. Can be quite painful. Slow to heal. Huge impact on quality of life.
So for nursing students, what's the absolute cornerstone of treatment for CVI and venous ulcers? Healing and preventing recurrence.
One thing stands above all else. Compression therapy. Using bandages or stockings to provide sustained pressure, helping push that pooled fluid back into circulation and supporting the tissues.
But critical safety point before you slap compression on someone.
You must assess their arterial status first.
Oh.
Always check an ankle brachial index, the ABI.
Why?
Because if they also have significant peripheral artery disease, say an ABI of 0.4 or less, putting strong compression on that leg could critically reduce already poor arterial blood flow and cause tissue damage or necrosis. Compression is contraindicated in severe PAD. Huge safety check.
Okay, assuming their ABI is okay for compression, what else?
Meticulous wound care for any ulcers, usually using dressings that maintain a moist wound environment. Good nutrition is vital for healing. Need adequate protein, vitamin A, vitamin C, zinc. Patient education is key too.
Educational.
Leg elevation whenever sitting or lying down. Get those feet above the heart level. Encourage activity, like walking, to activate the calf muscle pump. Daily moisturizing to prevent skin cracking. Protecting legs from trauma. Table 41.16 in Lewis's has a great breakdown of CVI care.
And antibiotics for the ulcers.
Generally, no. Routine antibiotics aren't indicated unless there are clear clinical signs of infection, increased redness, warmth, purulent drainage, fever. Overuse contributes to resistance, focuses on compression and wound care.
Wow. Okay, that was an incredible deep dive through the world of vascular disorders.
Yeah, we covered a lot, from that sneaky narrowing of PA
to the emergency of acute arterial ischemia and the potential catastrophe of aortic dissection or rupture.
And then the really common challenges of VTE and the chronic burden of CVI and those leg ulcers.
Hopefully listening to this has given you the essential knowledge you need to start connecting those dots when you see these patients.
We really hope you feel better equipped now to understand the why behind the symptoms, pick out those key risk factors, know what those diagnostic tests like the ABI mean.
And most importantly, apply those crucial nursing interventions, from giving meds safely to teaching patients how to manage their condition.
Exactly. Always try to see that whole picture. Connect the patient's story, their signs and symptoms, back to that underlying vascular problem. That's where truly excellent nursing care happens.
Well, thank you so much for joining us on this exploration today. We really hope this session has been valuable for you.
Yeah, from all of us here at the Deep Dive team, we wish you the very best in your nursing studies and your future practice. Keep asking questions, keep learning, and always be an advocate for your patient's vascular health. Because as we've seen, the impact goes far, far beyond just the blood vessels themselves.